Good morning, dear jury members, dear colleagues. I'm honored to present our case study as an oral presentation. I have nothing to disclose, and let me introduce our patient. He was
You have to move a bit closer to the mic.
He was 28-year-old male patient who came to our department as headache, vertigo, and nausea. Patient was vomiting multiple times, and he was also complaining about the dyspnea, especially during movements. Patient was newly diagnosed with arterial hypertension, audible systolic murmur, bilateral fluidothorax, and subicterus. We ran laboratory tests which pointed to acute kidney injury and further laboratory examination with unconjugated hyperbilirubinemia, and positive lactate dehydrogenase pointed to hemolysis. Patient didn't have any anemia upon admission. His clinical state, however, progressively deteriorated into pulmonary edema. Patient was still nauseous, hypertensive with chest pain. Echocardiography showed diffuse hypokinesis with low ejection fraction and mitral regurgitation of third grade. Respiratory insufficiency progressed. It was classified as acute heart failure on the background of malignant arterial hypertension. Patient did not respond to parenteral antihypertensive drug, loop diuretics, and also not for non-invasive ventilation, and needed intubation and mechanical ventilation. Because of the clinical symptomatology and lab result, we suspected thrombotic microangiopathy. Patient had features of hemolytic anemia with low haptoglobin level, positive schistocytes, lower platelets, and organ dysfunction in acute kidney injury. We suspected thrombotic thrombocytopenic purpura, although normal activity of ADAMTS13 ruled out this diagnosis. Therefore, we continue with thrombotic microangiopathy screening for hemolytic uremic syndrome. No infection which is associated with hemolytic uremic syndrome was confirmed. We also reviewed coexistent diseases. Patient didn't have any medical history, patient didn't have any chronic diseases. We did laboratory testing for autoantibodies, which were negative. Patient had malignant hypertension, and patient had nephropathy of unknown etiology. We also considered atypical hemolytic uremic syndrome, which is diagnosis per exclusionem, but complement factors 3 and 4 have been normal, and we can see that laboratory markers of hemolysis have been getting better. Patient was started on hemodialysis. We continue with combination antihypertensive drugs, and kidney biopsy was indicated, followed by rescue methylprednisolone treatment. Kidney biopsy showed malignant nephrosclerosis, so didn't help us with concrete diagnosis. Patient continued with hemodialysis, and after 4 months, he came to the hospital again. This time, we could see Raynaud phenomenon, and he also mentioned thickening of his skin in the last 2 months. There have been thickening at the torso, face, and especially at the upper extremities. We did, again, testing for autoantibodies. This time, ANAs were positive, and patient was diagnosed with diffuse cutaneous form of systemic sclerosis. Patient was started on prednisone, and because negative typization of autoantibodies, we also did screening for paraneoplastic etiology. PET-CT was normal, it pointed just pericardial effusion. Then we continued with organ screening with no lung fibrosis, no significant GI involvement. We did echocardiography again. This time, ejection fraction of left ventricle was 65%, just mild pulmonary hypertension and small non-significant pericardial effusion. We looked at the kidney biopsy once again in second reading, and at this time, the diagnosis was consistent with scleroderma renal crisis. The episode of pulmonary edema with features of microangiopathic hemolytic anemia, acute kidney injury, and hypertensive episode was also manifestation of scleroderma renal crisis. If we look again at the kidney biopsy, we can see typical onion-like skin lesions, especially in the interlobular arcuate arteries. We can see narrowing of the skins and non-specific ischemic changes at the glomeruli. Patient continued with hemodialysis for 17 months and later underwent kidney transplant. Scleroderma renal crisis is acute, vascular, potentially life-threatening complication of systemic sclerosis, especially in diffuse cutaneous form. Currently, we don't have any validated classification criteria. They are currently under development with this core set of items. And in 2016, there have been diagnostic criteria set as expert consensus from UK scleroderma study group. As you can see, part of this diagnostic criteria is also flash pulmonary edema. As for treatment, preferred antihypertensive drugs are ACE inhibitor. If patient needs parenteral antihypertensive drugs, vasodilators like nitrates are indicated. Early referral to nephrologist and early consultation with intensive care unit should be done because of the severe manifestation of this complication. Another option is hemodialysis. Sometimes recovery of the kidney function can take multiple times, up to 2 years. Kidney transplantation, in cases of feature of thrombotic microangiopathy, we can also go for plasma exchange or eculizumab. There is also rationale for endothelin receptor antagonist, although clinical evidence is lacking. In conclusion, we can say that scleroderma renal crisis is acute, potentially life-threatening complication. It is more common in patients who have positive anti-RNP3 autoantibodies, but they have been negative in our case. Clinical manifestation is increase in blood pressure, acute kidney injury, features of microangiopathic hemolytic anemia, and organ dysfunction. In our case, it was flash pulmonary edema. This patient had scleroderma renal crisis as the first manifestation of systemic sclerosis, which preceded skin manifestation. Treatment of choice are ACE inhibitors. Thank you for your kind attention.
Thank you very much. Roman, over to you.
Well, as usually in these complex cases, the best diagnostic test is to bring a hematologist, rheumatologist, and ID to one table. And I wonder if we would get some comments from them.
Thank you. Thank you. Ines from Portugal. Thank you for your presentation and congratulations. I was just going to call attention for the second look, because it was the second look of the biopsy, again, the second look of the radiologist that gave the diagnostic. A question for you. Did you do the capillaroscopy to the patient? And as I understand, the anti-SCL70 was negative.
Negative, yes, it was negative.
Regarding the capillaroscopy, and just a comment that scleroderma renal crisis can be rare, and it's very difficult to think about it if you don't have any diagnostic previously.
Exactly.
So it's just a call of attention. Thank you.
Yeah, thank you very much. Capillaroscopy was not done in the patient. Typically, we indicate this in them. Right now, phenomenon was confirmed in patient. There was a little problem with cooperation of the patient. He didn't want it to follow a lot of examination, so this was one of the reasons why it wasn't done.
Thanks. That was another great case. It's Maggie Larshay over here. So, yeah, it's interesting that his presentation of scleroderma with the puffy hands and Raynaud's seems to have started after the diagnosis of the hypertension and flash pulmonary edema. In retrospect, do you think he did have Raynaud's before this? And Raynaud's in an older person is always a red flag.
Yeah, it was the first presentation, although if we looked at the previous condition, he mentioned that he was having some defect at the finger a few weeks ago, and he was treated with antibiotics, but changes at the skin have not been present when he came to emergency department. So in retrospect, there could be something before, but it was overlooked. Thank you.
Thank you, and over there.
Yep. Here, Luc Mouton from France, very interesting. Did you ask him if he had swelling hands, or did you observe some telangiectasia or pitting scars, some signs that could help you out to make the diagnosis of scleroderma?
We haven't asked the patient, but thorough clinical examination was done in him.
All right, thank you very much. This was the last question. We have to move on. Thank you very much.
Thank you.